And again, I've confirmed the right tube feeding and that it's within date and that it was closed, okay? And if I would like, I can go ahead and open it at this point, or I can wait until closer to time to feed. I'm going to come on over here. I've already measured the length, so I need to make sure there's no air in the piston irrigation syringe. Whenever you access this, before you open it, you need to make sure that you clamp it off, because it is similar to the NG tube that when you open this, you do not want to allow air to enter, and you also don't want to let contents exit. So I'm going to come down here, and if you watch, I'm going to clamp the tube, and I'm holding it like this. I'm going to open up the tube, and I'm going to insert the syringe. Once the syringe is inserted, as long as the plunger is in, there will be no entry of air into the patient, and there can be no exit of secretions because this is here. So at this point, what I'm going to do is I'm going to pull back on the plunger, and I would be looking for aspirate here, okay? So I would pull back, and the thing you have to worry about is what type of tube do you have. Very commonly, your gastric tubes, whenever you go to pull back on them, they're going to collapse because they're smaller tubes, and you may not be able to check all of your residuals. If you have a tube that is in the small bowel, you never check residuals because you could end up clogging the tube, and also the tube is more likely to collapse whenever they're there. So if you are unable to check residuals, then you need to rely on the assessments that you've already made. Does my patient have a distended abdomen? Are they complaining of fullness, nausea, and vomiting? Are they having any pain here? What kind of assessments would tell me that they're not tolerating the tube feeds? If I can, however, get residual back, then I would continue pulling until I didn't get any more in here. If I got more than this syringe, which is up to 70, then what I would need, and let's just say that we did that, I would need to pull back on the plunger until the amount. When I take the plunger apart, I need to further clamp the tube. I'm going to take the plunger out, and then I'm going to re-clamp the tube and allow it to sit here. Then I'm going to come over and I would put my residual down into the tray, and be careful, and this is when personal protective equipment comes in handy. So besides just the gown, you might well want to have a mask that has a face mask on it to prevent, spillage and backing up. At this point, since I have the aspirate, I could put some of the aspirate over here on the pH paper and check the pH. Remember, your stomach contents normally are 5.5 on the pH scale or less, more likely 0 to 4. But also remember that they can be affected by medications and tube feedings. I've looked at this, I've confirmed. I have more potential for gastric residual, so I'm going to go back over here to the tube. In doing this, I'm going to come back and I'm further going to clamp the tube again. I'm going to open up the tube. I'm going to reinsert the piston irrigation syringe, and now that that's there, I can unclamp. And I'm going to pull back, and let's say I've only gotten about 20 more milliliters here. At this point, I now know that I had 70 of residual before, and I've got 20 here, so I need to remember that I've got a total of 90 milliliters of gastric residual. You need to make sure, based on your facility policy, what you need to do at this point. Some facilities, and this is a common range, say that if I get 250 milliliters or less of residual, that I need to now put it back into the patient. So what I would go through doing then, I would go ahead and reinsert this residual, and then I would clamp the tube off and go ahead and reclamp. And then I would come over and I would pull the gastric residual back up out of the container. And once I get it out of there, I'm going to come back over to the tube. Again, I'm going to clamp. The residual is inside the piston syringe. I'm going to go ahead and put the piston back in here again, and I can unclamp. And then I'm going to reinstill the residual. I'm going to clamp the tube again, and then I'm going to close it and put this here. Now, if you know, there is gastric residual sitting in this tube right now, so I must flush it to keep it from getting clogged. Depending on facility policy, you may see a different range of what you flush with and how much you flush with. Your textbook quotes that we need to flush with 30 milliliters of warm tap water, so what I'm going to do at this point, I'm going to come over and I'm going to pull up the 30 milliliters of the warm tap water, and making sure that I look at the amount on my piston syringe. I'm going to come back over here to my patient. I'm going to reclamp my tube. I'm going to open up. I'm going to put the piston syringe in here, and I'm going to instill the 30 milliliters of the warm tap water as my flush after checking my residual. I'm going to clamp the tube, take the piston syringe out, reclamp, and then I can unclamp where I was holding it. At this point now, I have gone through and I have confirmed the length of the tube and the pH. I have also gone through and checked gastric residual, and I'm aware that she had a total of 90 milliliters in there. I also needed to note the color, odor, consistency, and of course amount of what came out of her, because whenever I do my documentation at the end, I need to note the residual and the appearance of it and how she's tolerating the procedure and what I've done. I also need to be keeping up with intake and output. The residual was replaced in her stomach, so I don't have to account for that in the intake and output, but any flushes I put in, I need to put underneath the intake. And you also need to remember there are different types of intake. If it's the flush, then I need to note that in the chart. If it's the tube feed, then that needs to be recorded under the tube feed intake. If she does have any output, let's just say that she vomited, then I would need to record that underneath output, but in a separate area under vomitus. So always make sure you're keeping up with these amounts. And sometimes I'll actually bring a piece of paper and put it over here with a pen and keep up with those amounts as I'm going through and doing this. At this point, she's not having any issues. Her residual, meets the facility policy, so I'm to a point that I can actually administer the tube feeding. So what I'm going to do now, I'm going to come over here and I need to make sure that my piston syringe, doesn't have anything on it. If I need to rinse it out, I can do that at this point. I'm now going to pull the plunger out, because when I administer the tube feeding, I'm going to go through and do this like I did with the tube meds in one of the previous videos. It's best to let the tube feeds infuse by gravity if you're given bolus feedings, and we'll discuss continuous feedings in just a little bit. This is an intermittent bolus feeding. So I've taken the plunger out. I need to make sure again that I've got the appropriate flush behind this, but depending on facility policy, we're going to use warm tap water. I need to make sure that I've got the appropriate tube feeding that I'm actually going to be administering. Now, whenever we go through and I'm doing this, I need to make sure whenever I come and connect this, everything needs to be within my reach, because I'm going to be limited as far as how much I can move. So I'm going to come over here and I'm going to clamp her tube. I would have already established with her some way of communicating with me. So if she needs me to stop, if she's able to tell me, she needs to tell me that. I'm going to go ahead and take this loose, and I'm going to put the piston back in here. Now, if you'll notice, I am not unclamping at this point because I do not have the plunger in here to keep it clamped on its own. Also, I need to be able to keep it clamped while also holding this. You don't want this to be kind of flip-flopping all around, because it'll end up spilling all over your patient. So it's kind of like you need 4 hands here. You're going to have to practice your dexterity here. So again, you need to be practicing this skill. The next thing I'm going to come over and do, I'm going to grab my tube feeding and I'm going to bring the can over here. You need to be aware that you do not need to give these feedings too quickly, because you can cause your patient to feel discomfort. Think about what it feels like if you drink a Coke too quickly and it sits in your stomach. And that could cause her that kind of discomfort if you give this whole can that quickly, if that's what's ordered. So as a rule, they'll typically quote to you that you need to give 200 to 350 milliliters over about a 10 to 15 minute period. So it can take a little while. The other thing I would say to you is you do not want to fill this syringe up too high, because very commonly, whenever I give the food in here and I'm waiting for it to infuse by gravity, if my patient coughs or if she moves, the pressure can cause the food to come back up, and it'll end up on the ceiling, or it'll end up all over you and the patient. So when I fill this up, I probably only fill it up about half full, and then I let it infuse, and then I'll infuse some more. So when I'm ready, I'm going to go ahead and take the can, and I'm going to pour in, and I probably would only pour in about 30 to 40 milliliters of the tube feed. Then I'm going to unclamp, and this will allow, and I'm not keeping it really high. The higher you have it, the quicker it's going to go, because it infuses by gravity. So I'm going to keep it here and allow it to infuse slowly, and you will see your formula start to drain down from your 30 to 40 milliliter mark down to the bottom of the tube. Before the tube feed runs out of the syringe, you want to make sure and come back and reclamp the syringe, the tube, because you do not want air to enter the patient. Once I have infused that 30 to 40 milliliter mark, I need to come back over here and make sure I'm watching my time at this point, because I do not want to give, like I said, more than 200 to 350 milliliters over 10 to 15 minutes. I could pour another 30 to 40 milliliters, and then I can unclamp the tube and allow it to infuse by gravity. Again, the higher I hold this, the quicker it should infuse. The lower I hold it, the slower it should infuse. If I need to stop the infusion, then I'll need to clamp it. Okay, and so just be aware of your time frame. We're going to say that I have administered the order amount and solution of the tube feeding. I need to make sure that I keep up with that amount because I need to account for that in the intake under the actual tube feeding. Now I'm going to come over and I'm going to grab whatever the approved solution is for flush, and we're going to say it's warm tap water in this case. And following your facility policy, this tells you the amount that you need to flush with. At this point, making sure that I've got good hold of this, I'm going to flush it with between 30 and 60 milliliters of warm tap water. So I'm going to go ahead and instill this, making sure to look at my markings to see how much I'm instilling. And again, you need to put this in at a slow rate as well, just like you did your tube feeding. So I'm going to unclamp it and let it infuse. And I need to clamp the tube off before the solution gets out of the bottom of the syringe so that I don't instill any air into the patient. As I'm doing this procedure, I need to make sure that I'm assessing for the patient tolerance. I need to make sure that she's not having any nausea or vomiting. One thing always that's good to have around would be an emesis basin here. So in case if she does have nausea or vomiting or any of those kind of things, certainly it would be good to have the call bell within reach, so if I have any complications or anything like that, I could address those things at that point. I'm now done with my tube feed. I'm done with my flush. I'm going to then take the syringe out and clamp the tube back off, and then I can now unclamp and put this over here. At this point, I need to go through and make sure that she is tolerating the tube feed. I would certainly come back in about 30 minutes and make sure she's not having any complications and that she's having the right response to the tube feed. Most of your facilities require that you assess the gastric tube with every feeding, which means the length and aspirate if that is applicable as far as the pH, but certainly any gastric residual. So with every feeding, but then every 4 hours as well. So make sure you check your facility policy to know how often I need to be measuring it and how often I need to be checking gastric residuals. Certainly you can exercise nursing judgment, and any time that you think your patient's having complications, you could come in and you could assess for gastric residual at that point if the tube allows for it. Again, if the tube is in the small bowel, you're not going to be able to aspirate gastric residual. Some of the gastric tubes collapse, and you may well not be able to assess for gastric residual. So again, you need to be up on your patient assessments in general so that you know how they're tolerating the tube feeding or not. She says that she's fine. She's done well with the tube feeding. I'm not seeing any complications here. So now I'm over here to the point that I need to be cleaning up my equipment. And so I'm going to get to that. The other thing I need to make sure and tell you, though, in regards to tube feeding, they, at some facilities back in the past, they used to add food coloring to the tube feeding. We no longer do that because it can cause toxicity potentially in your patient. So just want to make sure and say that. At this point, I would go through and I'm going to go ahead and take this pad out from underneath Mrs. Smith, making sure to provide for patient privacy. I would go ahead and dispose of this in the appropriate container. Same thing with the tube feed. Since this is an intermittent feeding, this can needs to be disposed of. You cannot leave it open and hanging around because it is, it can set your patient up for bacteria and that kind of thing. You'd want to go ahead and discard of any pH paper that was there. You'd want to clean up any of this equipment. Certainly if this has not been date, time, and initialed, I would need to go through and I would need to date, time, and initial this equipment and make sure and keep it at the patient's bedside so I could use it again. I'm going to go ahead and take off my gloves. I'm going to go ahead and foam. And then I'm going to come up here and I'm going to replace Mrs. Smith's gown and provide for privacy. I'm certainly going to lower her bed down, but I'm going to maintain the head of her bed at the 30 to 45 degree angle for at least an hour, as we discussed before, because this is an intermittent feeding. Again, if this was a continuous feeding, then her head of bed would need to be up at 30 to 45 degrees at all times to prevent her from having complications, including aspiration. I'm going to ask her if there's anything else she needs at this time. I'm going to ask her if she's having any pain, and I need to address that at this point. Does she need to go potty? I need to make sure that her equipment is within proximity, so she has her call bell. Once I get the table clean, I would pull it back over here for her. And I need to make sure that, again, she is in the proper position. And I need to do some patient education with her and explain to her the importance of keeping the head of the bed up and what the reasoning is for that. Because some patients like to lay back down and you don't want them to have complications. You need to educate them on the importance of it. I need to make sure that her bed is low. I need to make sure that it's locked. And I need to make sure that there are no other safety issues at this point. I need to thank Miss Smith for allowing me to take care of her and give her her tube feedings at this point today. Make sure she has no other concerns. And then I'm going to foam, and I would exit the room. Thank you very much. Okay, in the first part of this video, we discussed how to go through and assess a gastric tube and to make sure that it's in the appropriate place. And also how to check residual. We also discussed how to do what we call an intermittent bolus feeding. So now I'm going to talk to you about the equipment that might be necessary for a continuous tube feeding. There is a video that's linked on your Moodle site for you about how to use this kangaroo pump, and it goes through and discusses the different settings and features and how to prime the tubing, and so I'll certainly refer you back to that for use of the pump. Now I'm going to show you some of the equipment and talk to you about a few things with continuous feedings. So if you'll look at this set here, this is what we call an open set. And the reason it's called open is because you can come and you can open the tops and you can actually add tube feeding or water or whatever is necessary. Now, the issue with an open set is that it lends itself more for bacteria. And so you need to be very vigilant when you're using this about foaming in and out, wearing gloves, following the policy so that you don't give any bacteria to your patient, cause an infection. If you'll look at this set, you'll notice that one bag is actually identified as the feed and one bag is actually identified as the flush. Your patient may or may not have a flush ordered. So you need to make sure and know if your patient is on any fluid restrictions or if a flush is ordered or not. If they are on restrictions and no flush is ordered, then you need to come through and based on whatever equipment you have, this flush should be clamped and not being in use. If the flush is ordered, however, you need to make sure you follow your facility policy for what should be placed in this. Most facilities tend to use either warm tap water, some facilities use sterile water. You need to make sure and look at your facility policy and know that any extra fluids that you add into your patient certainly can change their fluid and electrolyte status. The other thing you need to be aware of is how much of this your patient is getting, because you would need to account for this as water flush in your patient's intake. The other thing would be the actual feeding, and you need to know what the feeding should be so that whenever you add this into the open system, you add the appropriate type of feeding and the appropriate amount, and you're keeping up with it under intake for your patient's tube feeding. Now, whenever you're putting this stuff in here, you'd want to start off with a brand new set, and you would need to make sure that you use the label that would put the date and the time and the initials, and you would need to put a label on both bags here so that you know when it was hung. Anytime you have an open set like this, most facility policies will tell you that this set is only good for 24 hours because of the risk of the bacteria and infection. So that's why it's important. If you come into the room and this is not labeled, best practice states that you need to throw away the set and you need to hang a new one and you need to start all over again. If you ever have any question, it's better to start over again. So when you came in, I would add in whatever the appropriate flush was if it was ordered, and then certainly clamp this back up here at the top. And then you would add in whatever the appropriate feeding is. Now, before you add more feeding to this, most of your facilities are going to have you rinse this bag with some type of fluid. Most of your facilities have you rinse it with sterile water, and then you need to dispose of the sterile water. You do not leave it in here. That way you're cleaning out old tube feeding before you put in new, thus helping prevent the introduction of bacteria. So if you'll look, again, it's open because you can open the tops. You usually will have two different bags, one for a feed, one for a flush. The flush may or may not be used, and you need to make sure that you're accounting for the intake and output. Now with this system would run through this kangaroo pump, and again I told you need to refer back to that video, but on the video it will show you a way that you can go through and you can see the amount of tube feed that has infused and you can see the amount of flush that has infused. Make sure that you write those amounts down before you clear the pump, because once you clear the pump those values are gone and you won't be able to retrieve them again and you won't be able to keep up with an accurate intake for your patient. The other system that I'm going to show you is actually a closed system. The reason this is called a closed system is because your tube feed actually comes in a closed container, and you will actually spike the container with the spike that comes in the set that goes with it. Now it does have a bag over here for the flush, and you can open and close this, but more importantly, it is a closed system because I'm not adding formula as far as pouring it in and needing to rinse it and all this. This is the preferred type of system because a closed system helps decrease your risk of infection. Now with this, normally, and this depends on your agency policy, so make sure you check on it, normally your tube feed is good for 48 hours to hang and run. So you could hang it and let it run for 48 hours based on your facility policy, as long as you haven't had to change the bag. Once you have to change the bag or the container, then you need to change the whole set. And this depends again on your facility policy, so make sure you go through and look at that. But you always need to make sure that you've got the appropriate type of tube feeding. You need to know the reason for it, and you need to be able to educate your patient about it. And you need to make sure that it's within the expiration date and that there are no issues. You'll also see that they'll usually label these not for IV use and shake well before use. So make sure you read any of the labeling and make sure that everything is appropriate for it. Again, check the expiration dates. Make sure there's no openings, no leakage. Examine the top and make sure there's no issues with this. Again, you would need to date, time, and initial. So I would come up here and I would date, time, and initial, you know, when this was hung. I would also put a date, time, and initial on the water flush bag. If the water flush is not ordered, then you need to clamp that off for your patient. So always make sure that you verified your patient order for the tube feeding and the amount, the rate, and all that kind of stuff as far as what's ordered. And then you'll control that through the pump. Some facilities do not use pumps, and I'll have you refer back to those policies and procedures at that point if they do not. Evidence-based practice supports the use of a tube feeding pump, so you can ensure that your patient gets the right amount hourly, the right amount of water flush, keeps up with it, and helps you keep track of the intake and output for the patient. Thank you very much.